you, Madeline, and thank you, Jason, our NHMA staff for a great job in pulling together this number 3 of a series of webinars on biomarker testing, improving access to improved care. And on behalf of the National Hispanic Medical Association, I'm Dr. Elena Rios. I'm President and CEO. We're very happy to partner again with Amgen, who has provided us support to be able to discuss something that's very important, especially to cancer patients, the importance of biomarker testing. We have, let's see, I have a couple of comments here I want to make. The National Hispanic Medical Association is a nonprofit association representing 50,000 licensed Hispanic physicians in the United States. Our mission is to empower physicians to lead efforts to improve the health of Hispanic and other underserved populations. In collaboration with all of our partners, we work with federal government as well as states and state medical societies, residents, medical students, and other public and private sector partners. And again, we're really excited to host this series of webinars because we want to highlight the need to increase access with the use of biomarker testing among physicians. Our first speaker will be Dr. Estelamari Rodriguez, who is Associate Director of Community Outreach and co-lead of the Thoracic Site Disease Group of the NCI-designated Sylvester Comprehensive Cancer Center at the University of Miami Miller School of Medicine. She's a board-certified doctor in medical oncology and hematology and has a special interest in the early detection of lung cancer and developing programs to eradicate healthcare disparities. Following Dr. Rodriguez will be Hilary Gee Goeckner, a senior state and local campaigns manager of the American Cancer Society Action Network, or ACS-CAN, the advocacy affiliate of the American Cancer Society. In this role, she leads with the staff and coalition partners across the country to improve access to comprehensive biomarker testing, clinical trials, fertility preservation, and other healthcare access issues. Then we will have a roundtable where both of our speakers will be joined by a very important person, a patient, to discuss also her experience with biomarker testing. And that is our 3 people. And the patient's name, I'm sorry, is Julia, a patient advocate that has benefited from biomarker testing. So everyone watching us live today, we please ask you that you mute your microphones, and we are going to have a Q&A box for questions. We aren't going to be showing everyone. It's not a webinar. It's not a meeting, so we won't be able to see the hand raised feature. The recording will be housed on the nhmamd.org, our website, and our YouTube channel next week. And the slides also will be available. Next slide. The agenda I mentioned already. I think just to reiterate that after the roundtable discussion, we will be, not after, during the roundtable discussion, we will have Q&A from the audience, and we ask the audience to please put those questions in the Q&A box. The learning objectives are to educate health advocates about biomarker testing among Hispanics with cancer, and to discuss policies that are potential for state solutions to barriers of biomarker testing. Next slide. So Dr. Rodriguez, do you want to take it away? Thank you very much for being here today.
Great. Dr. Rios, thank you so much for inviting me again to participate in this very important webinar on the topic of biomarker testing, which is something that as an oncologist that treats patients with lung cancer and breast cancer is really at the heart of selecting the right treatment for the right patient. And the reason why we're having this discussion, why I think it's so important for providers to learn about this, is that many of our Hispanic patients that either have limited insurance or have difficulty in communication and getting information are really not getting tested. And I think that the more that we do to educate, the more our patients will get the right treatment. Next slide. So cancer mortality among Hispanics, let's start here. So, there's this Hispanic paradox that always people mention, that Hispanics overall have better life expectancy than non-Hispanic whites. But if you look at the number one cause of cancer of death for Hispanics, it remains cancer. So cancer is really a killer of our family members who are Hispanic, and it's something that we need to make sure that our patients get the right treatment, because even if the life expectancy may be a little bit better, once you get cancer, if you don't get the right treatment, you would really suffer. And this is what we're having this discussion. So the number one cause of cancer death for both men is lung cancer, and for women is breast cancer, but lung cancer is second in terms of presentation, but also a big problem for mortality. So these are cancers where we have learned a lot about treatment by selecting the right treatment. Next slide. So I mentioned that once patients get diagnosed with lung cancer, Hispanics can be at a disadvantage for two reasons. One is that there's a lot of barriers that the NHMA has worked very hard for a long time to eradicate by having providers who can communicate better with patients, but also the biggest barrier remains insurance. So 19% of Hispanics don't have usual insurance. So that limits really the whole continuum of care. And when we look at Latinos that have lung cancer, 16% of them are less likely to be diagnosed early because they don't have access. Once they have access, they are equally likely to receive surgical treatment. So that's in the middle, that Hispanics, which are in blue, you'll see about 20% will get access to surgical treatment compared to white Americans. But for patients that get diagnosed and have advanced disease, which is the majority of patients of lung cancer that I treat, 26% of them are more likely to not receive any treatment. So this is really a topic that I'm really interested in, because either they don't receive treatment because it's not offered, or they don't receive treatment because there's some kind of nihilism from the family that we don't want to pursue treatment in advanced disease. But I guess the message is that we have made so much progress in the treatment of cancer by understanding biomarker testing and selecting better treatments for patients, that is really critical that we educate our patients as primary care providers that even if you have a diagnosis of cancer, it is important to meet an oncologist, and it is important to get all the information that you can get so you can get the best outcomes. So we know that when we look at this whole story of Hispanics, the time that it gets for them to get diagnosed, and when they get diagnosed with advanced disease, how many of them don't get any treatment, we see that 16% of patients who are Hispanic are less likely to survive 5 years compared to white Americans. And that's for lung cancer, but we have seen the same data in colorectal, in breast cancer, in liver cancer. So it's really an area of need. Next slide. So what is biomarker testing? You may be wondering, why are we talking about it? I didn't learn about that in medical school. Why is it important? Next slide. So biomarker testing is really any molecule that can be measured in the blood, in the tissue, even in bodily fluids, to help inform treatment decisions. And this is really what precision medicine has really changed for patients, because by doing this test of the tumor characteristics via blood or directly in the tumor sequencing, we're able to select the drivers of the cancer that we can target and hopefully get better outcomes for patients. So there's biomarker testing in general, which I mentioned can be done in different tissues, but what we call comprehensive biomarker testing is when we actually either have a test of DNA in the blood of the tumor or in the actual tumor to understand the whole genome of that tumor and what's driving it. And this can help the healthcare team pick the right treatment for the patient. The current guidelines for treatments of lung cancer in advanced disease recommend that broad molecular testing is done at the time of diagnosis, not when patients progress or not when patients have really failed everything, but really from the beginning, because patients do better with the right treatment from the beginning. So really genomics, which is the understanding of the genome of the cancer, and biomarker testing, which is understanding these markers that drive the tumor and allow us to pick the right treatment for the patient, have really revolutionized discovery and investigation of novel agents and targeted therapies. Next slide. So currently, I treat lung cancer mostly. So currently 35%, so a third of patients with advanced non-small cell lung cancer have a known driver mutation that we currently have a treatment that we can order that is approved by the FDA. And some of these treatments have been recently approved, like some of these medications were not available before the whole era of COVID, and they got approved during COVID. So we have patients today who are, for example, that have red fusion alterations that are rare, but if you treat enough lung cancer, you'll find them. patients that have KRAS G12C mutations, which are very common, that didn't have these options before, and now they have better survival because of these treatments. But also these treatments that are targeted, the advantage of them is that they're really going after the cells that have the genetic abnormality that is causing the cancer. They're not going after every cell of your body. So that's very different than traditional cytotoxic chemotherapy that kind of, to kill the cancer cells, kills a lot of good cells in the middle. So hopefully these treatments are better tolerated, and we've seen patients really stay on treatment for longer with these options. Next slide. So I'll show you, one, I think pictures speak a lot about why we're talking about why this is so important. So this is a patient that was treated by one of my former partners here in Miami. And on the left, in the lung, this is a chest X-ray of a woman who was Asian, never smoker, who presented with lung cancer, was very short of breath, was actually in the ICU. And in the lung should be black, and you see all these white kind of fluffy changes in the lung. These are all lung cancer cells, and that's why the patient is so ill. And this is the beginning of the understanding of EGFR mutations in lung cancer. And we had access to one of the drugs for this mutation, which was given to this patient. And this is not a typo. The patient had a remarkable response to this treatment that was targeting this mutation that was driving her cancer within a week. So this is something that can work fast. I mean, this is really the extreme. Sometimes it can take a couple of weeks, but definitely something that works more effectively than chemotherapy. Next slide. And as I mentioned, this knowledge of the biomarkers and the genomics of the cancer has really driven discovery and treatment. So if you look at the last 20 years, all these pills are targeted treatments that have been discovered because we know the science of the genomics of the cancer, and we can select treatments for patients. And just in the last 2 years, I covered for you some of the new approvals like the FDA, and most of these are approvals in targeted therapy for very rare mutations called EGFR exon 20, KRAS G12C, MET exon 14. So these are all kind of like an alphabet of mutations, but once you if you don't find it, you're not going to be able to offer this to the patient. So the first step is to test. Next slide. So access to biomarker testing is what we're here to discuss. Next slide. And I wanted to show you that when we look at the data, this is very recent data that has been presented in the last year, looking at across our nation, how many patients with lung cancer get tested by the time they start treatment. And we're really doing very poorly for all comers. We only test about 50% of patients for broad molecular testing at the time of diagnosis. And we know that patients that adhere to testing early have a decreased mortality risk of 11%. So we're actually, in a way, just not doing that test. We're already having patients at a disadvantage in terms of survival. Next slide. And I think what is more striking is that there are significant disparities in testing. And this is something that should be avoided, that there's no reason for this, that if patients don't get tested and they're in a way kind of discriminated against, that they're not offered the proper test, we are seeing differences in survival by race that shouldn't exist because you're not really giving patients access to the right treatment. So this is a real world cohort from the Flatiron database that looked at 14,000 patients with lung cancer. This was presented last year at the oncology conference that were diagnosed and treated within 120 days. So these are patients that were going to get into treatment. And we found that Black patients, for example, were less likely to receive NGS testing. And because they were not getting this biomarker testing, they were less likely to participate in trials for some of these drugs. So in a way, we're limiting access to trials, we're limiting access to treatment, and we're impacting survival for patients. Next slide. So this is just kind of to show you the number in the next slide. Blacks are here on the middle column. And when we looked at ever tested for NGS, it was 39% of Blacks and 50% of whites. So there's a big discrepancy here on testing, and we need to wonder why is that. Next slide. So there are many reasons for this. I mean, the NHMA has done a lot of work trying to eradicate disparities and access barriers for Hispanics, and there's a lot of reasons for it. But I think there's some of the reasons that are really shouldn't exist are implicit bias. Like if doctors are meeting two patients with lung cancer and they have a bias about this patient is likely to have a mutation and this likely is not likely to have a mutation, that's something that the provider is deciding for the patient without really doing the test. And I think some of it is that some of these mutations, like the patient I presented, were first described in Asian women who were non-smokers. So there are a lot of patients who are minorities who have a smoking history who may not be offered the test because doctors assume they're not going to find this mutation. So that's one thing that we can change with education. Health literacy and awareness is key. So if we have patients that come to our office and we have a patient advocate that's going to speak to us today, and patients can really change this because patients can demand these tests. So we definitely have seen differences in who comes to the office with this information demanding this test. So we need to kind of educate our Hispanic patients that they need to demand this testing at the time of diagnosis. There's also issues with tissue insufficiency, that sometimes we don't have enough tissue to test. Fortunately, there's some tests that you can do in the blood, but we also need tissue to do the right comprehensive test. And some patients don't agree to have a second biopsy, but I think we need to educate them that it could be critical for the right treatment. Health insurance coverage, I mentioned at the beginning, from the get-go, Hispanics are at a disadvantage. 19% of Hispanics don't have health insurance coverage. So that in itself limits getting testing that costs money that would really impact treatment. Physician awareness is what we're here to discuss, that this is something that was not available when I went to medical school not that long ago. So this is something that we all have to learn that is important and is part of the treatment. And then there's also disparities by where people live. So like in rural communities, there's less access to specialists, less access to testing versus in urban centers, in big academic centers that have access to clinical trials. And then the part of this that I think speaks to my heart is really fatalism that I've seen in my own family, about that if you have a diagnosis of cancer and things are not going to go well, you don't need to see an oncologist. It's better to stay home. It's better not to tell abuela that they have cancer. We don't want to mention that word. But in reality, this we need to change, because I have patients that have been alive and that we never thought would have survived cancer because we have better treatment. So I think if we, from the get-go, let our patients, our family members stay home and not really seek care, we're not really giving them all the options that are available today. Next slide. So that's it. I just want to tell you that, things have changed. Patients are getting treatment, and it's important and upon us to offer them the right treatment from the get-go by doing testing. Thank you.
Oh boy.
Great. Thank you so much. Good morning, everyone. I'm Hilary Gee Goeckner with ACS CAN. We are the policy affiliate of the American Cancer Society, working in every state and territory to advance public policies that help with cancer prevention, detection, and access to care. We have staff and volunteers working at the local, state, and federal level on cancer fighting policies. And biomarker testing is a big priority for us because, as we heard from Dr. Rodriguez, this is really about connecting patients with the most effective treatment for their cancer. And this is really game-changing. Just like she said, there are patients who maybe thought they might only have a few months to live, or if they were receiving treatment a few years ago, would only have a few months, who are thriving years later and just doing really well and living a really normal life, good quality of life. Some of these targeted treatments that are based on biomarkers have much lower side effects, fewer side effects than more generalized treatments like chemo and radiation. So on the next slide, please. We've talked a little bit about some of these barriers to biomarker testing, but really all of these things need to align for patients to have access to appropriate biomarker testing. That the test is available, there's sufficient tissue when a biopsy is performed at diagnosis, providers know to order the appropriate test, and the facility has the resources to run that test. Patient's insurance covers that testing, and then the test is interpreted, and an appropriate treatment is available based on those biomarkers. And so ACS CAN is really focused on this step here with the red arrow about insurance coverage of appropriate testing. Even many patients who have health insurance, their insurance plans won't cover the testing that they need to determine the appropriate treatment for their cancer. Or their insurance will only cover a single gene test when a multi-gene panel would make much better use of that really limited tissue, which is particularly a problem for lung cancer patients. And so these barriers that we see here results in lower testing rates among non-white populations, patients with lower incomes, people insured by Medicaid in their state, and people receiving treatment outside of academic medical centers. So if we don't act to improve access to appropriate biomarker testing, we could see the already unacceptable disparities in cancer outcomes actually increase as people who have the means to pay out of pocket for biomarker testing or go to an academic medical center or have better insurance, more likely to get this testing that enables them to get on the most effective treatment for their cancer. So on the next slide, ACS CAN worked with a diverse group of partners representing healthcare providers, other patient advocacy groups, and others to develop model legislation to improve patient access to comprehensive biomarker testing. And so this is looking at requiring insurance plans to cover biomarker testing when it's supported by medical and scientific evidence. And so this legislation requires coverage of biomarker testing if the test has been approved or cleared by the FDA, or it's an indicated companion diagnostic for an FDA-approved drug. CMS coverage determinations, either national coverage determinations or local coverage determinations. So basically, if Medicare enrollees are able to get a particular biomarker test, it should be available to people with other types of insurance as well. And then nationally recognized clinical practice guidelines and consensus statements. So thinking about things like the National Comprehensive Cancer Network has guidelines for biomarker testing that are very widely used and widely cited. So sources like that, or particular cancer types, or the Children's Cancer Group has insurance guidelines as well. So if any of these sources of evidence are met, insurance plans must cover biomarker testing. Next slide, please. And so we've been working over the last few years to advance this legislation at the state level, and that those requirements on insurance plans to cover comprehensive biomarker testing apply to state Medicaid programs, as well as many private insurance plans, those that are regulated at the state level. Large employer-sponsored plans are not subject to state regulations. However, they are much more likely to cover the biomarker testing that patients need. Same with Medicare, that's determined at the federal level, but patients there have much better access than patients with Medicaid or with small private insurance plans. And so as you can see here, we've had quite a bit of progress. This legislation has been passed and signed into law in Arizona, Illinois, Louisiana, and Rhode Island. In California, it is up for a final vote as early as this Friday, and if that goes well, will go to the governor for signature. And then there were also bills introduced this year in Minnesota, New York, Ohio, and Washington. Most legislative sessions have wound down for the year. We're anticipating even more activity next year, including legislation in Texas, also your neighbors in New Mexico. So hope to see a lot more progress here on states with bills passed to expand insurance coverage of appropriate comprehensive biomarker testing so that more patients are able to find out which treatments would be most appropriate and access those. And, you know, providers have a huge role to play in helping advance proven policies like this to expand access to biomarker testing. Lawmakers generally, state legislators particularly, it's very different than members of Congress who have a lot of staff and this is their full-time job. Most state legislators have a day job. A handful of them are physicians, but many are farmers and ranchers and lawyers and any other kind of job that has some flexibility to allow people to leave for a few months at a time and go work in the state capitol. And they're really not experts on a lot of the issues that they're expected to work on. And particularly when you think about something that's so seemingly complicated or as intimidating as biomarker testing and cancer treatment. It's really important that physicians and patients and others help educate them about the importance of biomarker testing and really kind of simplifying it down to this is about getting patients the most effective treatment for their cancer. So, you know, sharing your stories as physicians and elevating the stories of your patients is hugely important to helping lawmakers understand what this means. Otherwise, they're just hearing from lobbyists for the other side, which in this case is often insurance companies that don't want to have to pay for testing, which can be somewhat expensive, although it can result in later cost savings. So strongly encourage you all to get involved in advocacy. ACS CAN makes it really easy. We're running policy campaigns in every state and would love to get you involved. And with that, I will hand it back to Dr. Rios for some discussion.
Great. Well, thank you, Hilary. I think that was a great discussion about the great presentation about the importance of seeing progress with biomarker education and awareness among the medical profession, and also getting translated into legislation where we know how important it is to educate and advocate to the legislators. As you mentioned, they're not the experts. So we are here to help. The NHMA organization actually has state chapters in different states that you mentioned, especially Texas and New Mexico, and in the states like California and New York that you mentioned that have bills already introduced. So any help we can do, let us know. So glad to have you today. In terms of the roundtable discussion, can we just take the slides off for a minute? Yes, very good. So we can see each other. And I want to introduce again, Julia, our patient advocate, and Dr. Rodriguez joining Hilary from ACS CAN. So Julia, let me ask you the first question. And let me remind everybody that is listening today to please put your questions in the Q&A box so that I can read them to the audience. But we have some questions already prepared also. Julia, just can you tell us from your experience, what was it like to hear about biomarker testing, or did you have to ask for it? What happened in your case? And tell us just a little bit about why you had the marker testing.
Yes, sure. So I have metastatic breast cancer, and I was diagnosed almost 10 years ago now. So I think the type of testing that was done back then is very different from the testing that is done now. Unfortunately, even to this day, I see patients today that are not offered what I was offered 10 years ago. But I think importantly, I have been on targeted treatment for all this time, and I have no doubt that that is 100% the reason why I'm still alive. There's absolutely no way that someone can take chemotherapy for that long of a time. So I think that Hilary put it really well, that patients don't want to just have more time. We need to want to live that time, right? We need our lives to be good and our quality of life to be good to live that long. I personally did have the point where I told my doctors that I did not want treatment anymore. The drugs I was on, they were so toxic, and my life was so miserable that I knew what it meant, but I was willing to stop. Fortunately, I had wonderful doctors and treatment and insurance that paid for testing that was able to find, a secret key that worked for me. But I can't emphasize enough how important it is to offer all patients that. And I think it's you can't not mention the fact that there are certain institutions around our country that have specialists like Dr. Rodriguez. Like they really focus on very specific type of treatments and cancers, and unfortunately not everyone accesses that level of care. And
I muted myself. Julia, thank you very much for sharing your important insights. Patients who are sick, no matter what the disease, but especially with cancer, and because we're talking about how to improve care and not have so much pain as you mentioned with the chemotherapy drugs, it's always hard for decisions that you have to make, and hopefully that you had support from your family and support from your doctors along the way. It sounds like you've had a long journey, but you seem very upbeat and positive about the difference biomarkers have made for you. And Dr. Rodriguez, if I could ask you to clarify some of the comments that Julia made, and let me ask you this: what's the real difference in treatment between biomarker testing for patients versus the patients who have cancer, like Julia, but do not receive biomarker testing? What could you explain that a little bit more?
Yeah, so
there is a big difference.
Thank you, Julia, for sharing your story, which is truly inspiring. And I think the most inspiring thing is that you're here sharing your story so other patients can be inspired as well, that testing and getting treatment has really allowed you to live with breast cancer. I think the question about the treatments and how are they different is that our understanding over the last 20, 25 years of the genes that drive cancer has allowed us to really kind of narrow down, can we turn off the switch that's causing the cancer growth? And that's not true for every patient. Like, you know, I mentioned that in lung cancer, which I treat, we know about 30% of the cases that we will understand the driver, we will have the treatment to stop that switch. There are many patients that, you know, it's disappointing that we don't find a driver, but there are mutations there and the science is moving really fast. So one of the other things that we have available in our cancer center, and they're available all over the country, are these trials that are basket trials, where you can join the trial if you have a driver mutation, but not necessarily, like if there's a drug that is approved for melanoma for a specific like BRAF mutation, one mutation, but that drug has not been approved for kidney cancer. Can you get that drug because you have that driver? And I think that's really where we want to go. We want to kind of treat patients that have these drivers and not wait for the whole process of getting drugs approved, and hopefully have more patients like Julia who are living well and thriving because they're on treatments that are kind of turning off the switch. But currently we don't have that for every patient, but there are, again, if you don't test, you're not going to have those options. And at least, you know, even when the tests don't reveal a change that I have a treatment, it does open the door for other treatments, other trials that may be available. And I think that that's the other part of biomarker testing, is that it allows patients to join clinical trials.
Okay, thank you for clarifying, Dr. Rodriguez. And it sounds like we have a future of hope for cancer treatment, and we're, like you said, we're on the fast track to finding more help for more people. Julia, we have a question for you. When you were going through the testing and diagnosis and treatment, did your provider discuss what they were testing for? And did you know about biomarker testing? Did you hear the term?
I don't remember if I heard the term biomarker, but I definitely do remember having discussions about the different drivers of breast cancer and the importance of looking for them. Again, I'm very lucky to have been treated in comprehensive cancer centers where it was really standard to be looking at these drivers and giving the patients the latest science.
Great. Let me ask Hilary, I know you're really focused on advocacy for change from a policy perspective. Do you see the legislation that you are rooting for will it increase access to other hospitals and other patients besides the comprehensive cancer centers?
Yeah, so that's a really great question. And the important thing about this legislation is it applies to all state regulated insurance plans. And it doesn't matter kind of where you use it. And what's really important, part of the reason we see the disparities now between academic medical centers and non-academic medical centers in biomarker testing rates is that often those larger academic medical centers, not only are the providers more specialized and kind of up to date on the testing recommendations, but also their facilities have the resources to cover the cost of testing often if insurance won't. Or they have the staff resources to spend days, sometimes weeks, fighting with an insurance company to cover a test that's really standard of care, whereas a community oncology provider doesn't have the time or resources to do that. And so this will help address some of those barriers so that the cost of the testing is no longer preventing patients from getting it or providers from recommending it when it's the right thing for a patient.
You mentioned state regulated insurance plans, so that doesn't Medicare, right? Is Medicare covered?
Medicare for older
covers
adults and large employer-sponsored plans are regulated at the federal level. However, those are the two types of insurance where we see currently they're much more likely to cover the biomarker testing that patients need. There's worse coverage currently for state Medicaid programs for lower income populations and for smaller private plans. So marketplace insurance, small employer sponsored plans, and then also state employee health insurance. Those are all subject to state regulations and would have to follow the rules for if this legislation passes in a particular state.
Phenomenal. So we need more states to know about this great legislation that more states need to pass so that we can really increase access to better cancer care for our patients. Dr. Rodriguez, if you were sitting in front of a legislator, what would you tell them was the #1 reason to pass this legislation?
So that I feel it's personal. I feel like, your family member that had cancer will do better if they have the right treatment, and you will want that for every of your constituents. So I think it's important that we make it personal, that cancer affects almost everyone, and it's not a rare disease. It's a #1 cause of mortality for many groups, and it's not something that patients have control, because it requires that you meet a doctor, it requires that you have tissue, it requires that you have insurance. So a lot of this can be facilitated, and I think the advocacy is key. I was curious from Julia, where can we tell patients to get information? Because I think that that's one part that, there's a big difference. I have, obviously some of our comprehensive cancer centers, we get patients that are very well educated, and they bring a book of questions, and then we have patients that are just lost, and everything we tell them doesn't go in. So I just, want to know from your perspective where patients can learn and get information.
Yeah, I think it really will be depending on what type of cancer they have. There are different organizations. I mean, I think ACS is one that has information for all cancers out there, but the NIH has a lot of information as well. But I really struggle with this idea of talking about the importance of patients educating themselves, because absolutely, I agree that each person can educate themselves, and it's in their own interest. But putting it on the patient is really bad, because we're saying that people that don't have the time, the education, they won't be able to. So those are the people that are not going to get biomarker testing because they don't come to their office asking for the testing. Like, it should not be on the patient. Just like clinical trials should not be the patient's job to go find the right one and ask the doctor about it.
Thank you. Thank you for that. You're right.
Dr. Rodriguez, we have another question here about cancer centers community cancer centers versus the comprehensive cancer centers. The community cancer centers, do you think they have a reverse incentive? And do you think that they profit from continuing the status quo, the profit from non-standard care approaches such as chemotherapy?
Wow, that's a
question from the audience.
That's a loaded question there. I think that, I mean, if patients do better, live longer, I think everyone's gaining, no? And the incentives here, I think what the question refers to is that standard chemotherapy or standard immunotherapy, where you just order it without looking at any test. No, it's not wrong, and you can continue because you build by the patient coming to your office to get an infusion, where a lot of targeted therapies we haven't mentioned, some are infusions, but a lot of them are oral chemotherapies where there is a different incentive pattern. So like you don't really get paid for a visit where the patient taking a pill. You do get paid to monitor that, and you do have to spend a lot of time trying to get the drugs to the patient. But I think there is something to be said about that sometimes maybe the initiative is just like patient is in front of you, you have chemotherapy in your pharmacy, you just give it. But I think the message I want to convey is that we have seen this in lung cancer, that if you start immunotherapy on a patient because you didn't have testing and you just had the drug in your pharmacy, and then you found out the patient had one of these biomarker driven cancers that you need to put them on a pill, there's actually a detriment. When you put the patient on the pill after the immunotherapy, they can have a very serious inflammation of the lung called pneumonitis. So you can actually cause harm by not doing things the right way. So I think, I know no doctors out there want to cause harm. And I think regardless of the incentives or what's in your pharmacy, you could really harm a patient by not giving them the right treatment. So that's my message.
Okay. No,
I'll add that in general, as advocates, we often encourage patients to get a second opinion. And then absolutely do get care with the doctor that you know and that is close to you and that you feel comfortable with. But I think it's never a bad idea with an illness as serious as cancer to make sure another expert is on the same page.
Yeah.
And I'll play devil's advocate here. I think insurance companies are trying to change to be more, not just about numbers, but about patient satisfaction. The whole concept of value-based care and quality care means that insurance companies need to understand that the patients are going to stay with them if they're getting quality care and if they think they're getting something that's going to be better for them, right? So they're going to have to change, and the incentives will have to change to be better for quality and value-based care. I
had one more thing to add that we haven't mentioned is the time it takes to get the test results. So I think some of the differences we have seen between community and academic centers in many settings is that the patient doesn't want to wait and the family doesn't want to wait for the test result. It could take sometimes 10 days. It's getting better. Sometimes things can take 3 weeks, but we make our patients, we don't make them, we really strongly recommend waiting, or we'll find a safe way to wait for the results because we think it's so important. So I just wanted to add that in there because there are very good doctors out there that just have a patient in front of them and they just don't feel comfortable waiting for the test results. So that I wanted to, besides the insurance, there's that other barrier, which is the wait for the test to come back.
Yeah. Well, that's good to know. Yeah, I think there's so many details and that's what the point of this discussion is to, and again, if anyone has questions from the audience, please put your questions in the Q&A box. Hilary, another question about the legislation. How can clinicians help to ensure that biomarker testing will be covered by insurance? What can they do if legislation is not being honored by a plan? And
Sure.
in a state where there is legislation, how can doctors help or the hospitals help?
Yeah, I think there's two pieces here. One, in a state that hasn't passed this legislation or hasn't taken effect yet, sharing your story and helping really personalize this issue for lawmakers. We really need kind of provider and patient faces to help make this issue more accessible and meaningful. That's so much more important than statistics and policy reports and talking points and cost saving analysis. It's really about putting a human face to this issue and helping policymakers realize, their wife who, had a terrible experience with breast cancer and had all of these horrible chemotherapies where you're just trying and failing on different drugs, trying to find something that might work when you're just kind of guessing in the dark. So I think sharing your story as a provider and elevating the stories of your patients is hugely important to getting smart legislation passed. And then once it is in effect, it's really important to make sure that implementation goes well and that insurers are actually following the rules. So when this is passed in Texas, where I think everyone is joining us from today, it's important to understand that this testing should now be covered for more of your patients, and to, if an insurance company is not following that policy, we can elevate that to the insurance commissioner or reach out to ACS CAN, and we'll help you navigate that process. But we need to make sure that once we pass good policies, that those are actually being followed. Fortunately, there aren't.
I'm assuming that the ACS CAN is not only proposing legislation, but helping to educate on how to implement the legislation, especially to our communities. And again, the National Hispanic Medical Association and other advocates for the Latino population, the African American population, the populations that, as Dr. Rodriguez mentioned earlier, we get the worst care, right, in the community hospitals or wherever, where you don't have that access to the best information. I think whatever we can do to help you get to the more advocates, the better in our communities for healthcare.
Absolutely, and provider associations are so important for supporting implementation, because if you weren't at the State House every day when we were debating this and following the rules and regs process to know when implementation takes effect, it's important to know that patients who have Medicaid, and in the past, your request for comprehensive biomarker testing has always been denied, and so you don't want to waste time with that, and you just want to go ahead and get someone started on a treatment, to know that the rules have changed and that you can now expect this to be covered and advocate for your patient if it's not.
That's great. So Dr. Rodriguez, let me ask you another question. I think we've talked about the importance of biomarker testing, but let me go back to the patient experience from the physician perspective. How can you talk to patients about biomarker testing? You mentioned they don't want to wait, but what's the incentive and the messaging for doctors to start telling patients about biomarker testing in these states with the new legislation?
I think that the advances in oncology care really have been driven by understanding genomics and biomarker testing. So I think I always tell patients that you have a diagnosis of cancer, but that's, we get a pathology report, but we're not done here. There's a lot of markers that will help me select the best treatment for you. So some are the markers that predict response to immunotherapy, and some are these genomic markers that allow me to select a pill. And every time I mention a pill to a patient, their eyes light up, because can I get that pill? And then I have to kind of say, this pill will only work if you have this mutation, so we should wait. And even if you don't have the mutation, we will select the best treatment for you. But we will also learn about your cancer and how your cancer is not like someone else's cancer, and we can pick a treatment or a clinical trial in the future that will be directed at those mutations. So I think it really opens the door for better treatments for patients. And that's what I spend a lot of time counseling patients, that we sometimes require a new biopsy or we need to wait for the test result.
Okay. Yeah, a lot of things to consider. I don't see any other questions. Let me see. Let me ask the doctor again, Dr. Rodriguez, in your experience, what has been barriers from the Latino patients? What do you think to let our advocates know?
I think the biggest barriers that many African Americans and Hispanic patients, because of all the institutional insurance barriers, get to us really late. So we meet a lot of patients in the hospital when we don't want to treat people that are like almost in the ICU and they can't breathe. We want to treat people who have a diagnosis where we can really have an impact in survival. So I think, one of the biggest challenges is that people do come sometimes very sick, and sometimes we do have to start chemotherapy, not immunotherapy, but just chemotherapy to get things under control before we do testing. But we do testing, we are fortunate enough that we can do some of this testing in the hospital so that we can actually get results that will really change lives really fast. But we know that patients have to wait a long time to see doctors. And I think that that's something that is part of this problem. Because if you don't get this test until you actually meet a doctor, and it took you 3 months to find a doctor or get insurance or change insurance, then a lot of that delay is really on the system. It's not on the patient. And we can change that. There's experiences. The University of Pennsylvania is doing this experience where they're doing the biomarker testing without patient meeting a doctor, so that the moment that they get a biopsy with a pulmonologist or the primary care doctor identifying lung cancer, they test. So by the time this patient meets a doctor that is going to make a decision, the doctor has the information. So there's a lot of ways that we can make this better. And I think one of the ways is to really educate ourselves about how this can be done. But I definitely, in the future, hopefully we'll have patients come in, not have to wait all this time to see a specialist, and not have to wait, have this test done from the get-go automatically, like a reflex test that is covered by insurances.
Julia, what do you think about that new model of at the University of Pennsylvania that Dr. Rodriguez just mentioned about getting a test right away without even seeing your doctor?
I mean, if that's doable, I think it's great. I think sometimes the type of test that the doctor orders depends on some of the history that the patient may discuss. So I think, I don't know if it's always possible, but that would be great. I think that in closing, I think one of the issues with this whole conversation, and we just have to be mindful of it as we discuss these pills and these new drugs, when it's communicated to patients, we always have to emphasize the fact that it is not a one-size-fits-all, right? So people often ask me like, what, you've been alive that long with MDC? What is the drug that you take? And it's like, no, it doesn't work like that. I can't, like everyone is different. And what really matters is this precision part of precision medicine. And we need to continue explaining the precision and focusing on the detailed tests and all of that.
And let me ask Hilary about the legislation. Is there a focus on the legislation on the importance of research? So much of medications and medicine in general is based on science and scientific knowledge. And the more research you do, the more inclusive research you do, especially for diversity. We're very interested in having diversity in all these clinical trial studies for new drugs or new testing. Is there a focus on, it would be great to have some type of incentive in the legislation to do a certain test or biomarker testing, but to put in funding for research to continue to do more research about the biomarker testing, like Dr. Rodriguez is mentioning, on other cancers, for example, within that state. I mean,
Sure.
Funding to the academic world for research, if it was put into these legislative efforts.
Sure. So there isn't research funding directly in this legislation. A lot of states
why not?
Well, a lot of states only allow a single subject in a piece of legislation. So this deals with insurance coverage. Okay. However, it does enable more patients to get the biomarker testing they need to enroll in clinical trials, which is hugely important because that's often a barrier to enrolling in a clinical trial. While the routine costs of clinical trials are now covered, the biomarker testing you need to find out if you are an appropriate fit for a particular trial is not covered, because that, how the process happens, you wouldn't even know what clinical trials you might be eligible for without having those results. So you really need the biomarker testing results first to find out what clinical trials you might be appropriate for. So this allows more patients to get clinical trials, participate in clinical trials, but also the results of biomarker testing support research that pharmaceutical companies and others are doing, having data when they're able to access it allows them to understand kind of more of what mutations are out there and what these different markers mean, so that we can move to, it really seems like we'll ultimately be moving more towards treating cancers based on the mutation, not the body part where we found them. So instead of, you know, breast cancer, and these are the treatment options for breast cancer, it's you have a KRAS mutation, and it doesn't matter if we found it in your prostate or your breast or your esophagus, these are the treatments that work well for that mutation. So it's much more personalized, as Julia was saying.
I think precision medicine is the future, and the future is now, the future is here. So thank you all very much. We are at the end of our discussion time. And Dr. Rodriguez, thank you very much again. Hilary, thank you very much for ACS, from ACS CAN. And Julia, thank you very much for your perspective as a patient with breast cancer. And we welcome all of you to stay in touch with NHMA and everyone that's on the call. The National Hispanic Medical Association has a few other upcoming events that I am to announce here. We have a COVID-19 virtual briefing session August 31st in the evening, 7 to 8:15. I don't see the topics yet, but it will be important and exciting. The Southern California NHMA chapter is holding their first in-person meeting, September the 9th, 6 to 9 p.m. At the University of Southern California, Caruso's Catholic Center, where we have a stellar list of doctors from about, I'm going to say 4 or 5 different hospitals in the Los Angeles area to talk about leadership and the importance of bringing together medical students and residents to learn about NHMA activities. Some of our staff is even flying out to talk about our vaccinations program campaigns and our All of Us research partnership campaign to get more doctors interested in enrolling their patients in the All of Us NIH research study. HIV chapter forum, this will be September 14th. I'm not sure which chapter, but that is happening September 14th. And the NHMA has an annual conference that will be taking place in Chicago, Illinois for the first time. So we're looking forward to that, April 27th to the 30th in 2023 at the Hyatt Regency. And again, I mentioned vaccinations. It's very important. We have so many, now we have monkeypox to worry about, as well as a continuation of COVID-19. And as we go back to school, I think it's an important time to remind young parents about the importance of getting their kids vaccinated and taking care of preventive behaviors, and teaching their kids about washing hands and keeping their distance, especially from other kids that are coughing. We have new websites, hispanichealth.info, that has bilingual information for providers as well as for patients, and our vaccinate4all.org again has lots of information. We keep it updated on latest information for our communities. And we ask everybody to consider being a champion, which just means that you're an ambassador for our Vaccinate for All campaign. And if you have any other questions, to please ask Vito at vgarrity@nhmamd.org. And thanks again to the staff, Jason and Madeline today. You guys did a great job. And thank you to Amgen for being our partner. And thank you all again for being great speakers. And we'll have everything on our website next week. Thank you.
Thank you so much. Bye.
Bye.